All right, so this is the second video in the COPD series. This one's going to be covering COPD prevention and maintenance by me, Nick Riesenberg. So prevention, some key aspects of prevention is avoiding or limiting risk factors. Smoking cessation, if you're a smoker, you need to be actively quitting or quit. Vaccinations are also key and vital to anything respiratory and keeping you from acquiring any of those illnesses, and then just having an active lifestyle, staying active. So over the risk factors, the key element is identifying and reducing exposure to those risk factors. So some risk factors are cigarette smoking. It's the most encountered and easily identifiable risk factor for COPD. Individuals that smoke, smoking cessation is highly encouraged. I mean, people shouldn't smoke either ways. It's obviously not good for you, but if you have COPD, it is going to further uh, impede upon your ability to live a effective lifestyle and be happy. So, and it's going to shorten that life. So reduce exposure also to any occupational dust, fumes, and gases. If you work somewhere or have somewhere that you work in a factory, you may have to look into a new job if it's already affected you to the point that you have COPD, because it's not going to stop doing that. Reduce exposure to household and outdoor air pollutants. So identifying what factors are in your life that are maybe contributing to that COPD, or even if you don't have it, it's just limiting your uh, risk, your association with these risk factors that can also help with that. So smoking cessation, it's key intervention for all COPD patients who continue to smoke. Approximately 40% of those with COPD are current smokers. So that's almost half. And that's not even saying past smokers, it's saying current. 40% still smoke. That's that's not good. That's not good. And I would hate to see what the number is for who were current or did smoke, because I bet it would be very close to the 100%, at least in the upper 80s to 90s, if not 100%. Smoking has a negative impact on prognosis and progression in COPD. For smokers with COPD, quitting can be more challenging for others who don't have COPD. This is due to a couple different things. Greater nicotine dependence. One of that reason is being because you don't develop COPD overnight. This is something that is progressed throughout time. It's not very common to see people in their 30s. It's starting to happen more now, but in their 30s having COPD, it's not very common. It's normally in your 50s or 60s when you're getting older, because of that prolonged exposure to that risk factor. So they have a greater nicotine dependence because they've been smoking for a long time. Lower self-esteem, lower self-efficiency, and depression, and all those tie in together, because if you're not able to live actively and get out of the house and you have trouble breathing everywhere you go, that's going to lower your self-esteem. And obviously that's already lower your self-efficiency, which is going to make you depressed. And I'm going to go into that a little bit further here. So still on smoking cessation, but depression is more common in smokers with COPD and can contribute to their failed attempts to quit. 40% still smoke. Because of these conditions, encouragement is a major component of smoking cessation. As a provider, or us as the RT as a provider, or anybody that's involved, it is very important that we always encourage them to quit and give them good feedback when they do well or they're trying, and try to help fuel that drive to quit if they're actively trying, because it's a hard process. Anybody who's ever smoked, I know I did for a very short time when I was younger. It's not an easy habit to kick, probably because of, one, it's a habit, and two, of that nicotine dependence. So it's also important to relate to friends and families that you should encourage them in their quitting and help them any way that you can in that. And despite the adverse conditions, when effective time and resources are dedicated to smoking cessation, long-term quit rates are 14% to 27%. So that's a fairly decent amount of people that are really that end up quitting long-term. But it's really about just effectively helping that patient understand what is really happening and why that's causing such a problem. And that if you want these symptoms to alleviate a little bit, go down, or even extend your period of life, you're going to have to try to quit smoking. So vaccinations are another key aspect, because anybody with COPD, any kind of respiratory infection is just going to make things so much worse. So it's very important that we uh, illustrate to them that you need to get these vaccinations if you haven't already. So influenza vaccination and the pneumococcal vaccination decrease the incidence of lower respiratory tract infections. COVID-19 vaccinations are highly effective against the SARS infection, obviously. So that's something you definitely don't want to have, because that with COPD, I don't know if anybody else knows anybody personally, but I know someone from my past that was 48 years old that had COPD and got COVID, and they did pass away. They made it home efficiently, but they did pass away after a short time with that battle over. Or I say short time, it was over a month or two of fighting that. So that's something that you want to avoid at all costs. So the COVID-19 vaccination is very important. Tdap vaccination, routine shingles vaccination, RSV vaccination for individuals over 60 and or with a chronic heart or lung disease. So these are some other areas of prevention, but also maintenance, if you have it, that you would want to talk to your provider or look into this if you haven't already. So active lifestyle, this one's fairly basic compared to the other ones, but it's important to have an active lifestyle for prevention and maintenance of COPD, or just being a live person. You want to move around, you need to be more active. It's going to make all your aspects of being healthier a little bit better, most likely. So physical activity is a strong predictor of mortality. So if you're not being physically active, it's going to, lead you in the wrong direction. And being physically active can also improve your exercise capacity, which in doing that, it can help you in your daily living a bit as well, and where you need to go, if your breathlessness getting in and out of bed or going to the restroom or just getting on your clothes. It can improve on your symptoms and quality of loss across quality of life, across all grades of the COPD. So trying to be as active as possible. We'll talk more about pulmonary rehabilitation later, but that's a key aspect of that. It's just help you manage it a little bit better and be able to move around more efficiently. Oh, I accidentally skipped one. So COPD maintenance, key elements for this one: diagnosing if they have COPD, their initial assessment, the initial management and reviewing, and then adjust. So this is kind of a process. So I'm gonna go through this step by step here. So diagnosis, symptoms. Do they have any of the symptoms? Do they have any of those three cardinal symptoms? Chronic cough, dyspnea, sputum production. Risk factors. Do they smoke? Do they work in a place that has air pollutants? Do they use household chemicals daily or weekly? That could be going towards that. And then a spirometry test. We want to see, where they're at. What's that FEV1? We want to see if they do have an airway obstruction or airflow obstruction. So in the initial assessment, the FEV1, go 1 to 4, the standard, we're going to see where they fall in that. Or do they have a mild, moderate, severe, very severe airflow obstruction? And then symptoms evaluated by the CAT assessment that we looked at, that 0 to 40 scale. If they go over a 25, then we need to start thinking about a possible treatment. And then the dyspnea scale, cardinal symptom of COPD. And we want to see how out of breath they are, how their daily activities are being impinged on that. Their exacerbation history. Exacerbation is just a flare-up of COPD that may send them to the hospital. A lot of times it does. So we want to know, are you having frequent exacerbations? Have you been to the hospital because of an exacerbation here recently? Their smoking status. Are they currently smoking? Are they trying to quit? Did they used to smoke and have they quit? And blood eosinophil count. So this one, studies have shown that blood eosinophil counts are higher in COPD patients, and that the counts predict the magnitude of the effect of the corticosteroid, the inhaled corticosteroid, which it can be a part of the regimen, which we will talk about a little bit more. So we want to know what their blood eosinophil count is as well. And then A1 antitrypsin. So the reason for that is if there's a delay in the diagnosis is led to identification of some of a ATTD in patients, which is alpha-1 antitrypsin deficiency. A low concentration of less than 20 is highly suggestive of a homogeneous deficiency, which increases the risk for COPD. So we want to see where they fall in that too, because we're still, and this is the point, we're still really assessing where they're at in that, if they have it, if they don't, or how progressed it is. And then core morbidities. Do they have diabetes? I wouldn't call that necessarily morbid, but it can affect to that. Do they have heart issues, or do they have CHF? You want to see what other things could be tying in with that COPD that might make this a more grave situation or progress it in a way. So then you want to review what you've went over, their symptoms, again, their exacerbation, smoking status, exposure, Inhaler technique and adherence, that's important because if our jobs are to tell people how to use their medication efficiently. I don't know, I'm not sure a lot of people can attest to this. You see people in the hospital that they're not using their inhalers correctly, and that can cause more exacerbations because if you're taking your medication but not effectively the way you should, is it really helping? And that's something we need to go over with them and review with them. And physical activity and exercise, we need to know how active they are, if not, or if they are. The need for pulmonary rehabilitation, they may be to the point that they need that help, and that's a good alternative. Their self-management skills, do they have a written action plan? That's a good thing to have to plan if you have an exacerbation and just know what you need to do. Need for oxygen, non-invasive ventilation, lung volume reduction, palliative approaches if they're that far progressed. Vaccinations, have they had theirs, or are they considering it? Management of those comorbidities, and an annual spirometry is recommended so we can keep track of how that disease is progressing. And then you have the adjustment period. So we can adjust their pharmacological therapy. Do we need to add a LAMA? I'm going to go into medications here in a little bit as well, but do we need to add to that? Do we need to increase the dosage? Or are they okay with just a short acting or a long acting bronchodilator or beta 2 agonist? And then non-pharmacological therapy, can we adjust that as well? Do they need to be on anything else that's non-pharmacological, or can we adjust the levels that they're on? So this is basically the breakdown of what I just all talked: diagnosis, symptoms, risk factors, spirometry. Then you're going to go into your initial assessment and go over those key things: FEV1, symptoms, exacerbation, history, smoking status, comorbidities, and then initial management: smoking cessation, vaccination, lifestyle, active lifestyle, pharmacological therapy, self-management, education. Talk to them about the risk factor management, their inhaler technique, how breathless they've been, and make sure they have a written action plan ahead for when something does occur, if something does occur. And then review all those with them again. And especially, I like to hint on that, like I said earlier, the inhaler technique is very important. We can prescribe things, well, not really us, but things can be prescribed to people, but if they don't understand how to use it and its effectiveness, then there's a good chance we're not really doing anything. We're not really helping in that way. We need to educate them in the way that they can help themselves, because I bet a lot of people do want to help themselves when they get to this point. Some people are a little bit past it, but if they are able to and want to be educated and help themselves, it is our job to do it. And even if they don't want to be, we need to let them know, because that's our job and that's important. Need for pulmonary rehabilitation, their self-management skills, because you're going to have it with a disease like this. And then you're going to go back into that adjust period. The medication, can we adjust anything on the medication, Shine, or non-pharmacological therapies, pulmonary rehabilitation, things that we might want to implement with them? Thank you.